Good day, everyone. My name is Emmanuel Ezike. I'm here to present on an innovative approach to leverage responsive feedback mechanism in preventing postpartum hemorrhage in Nigeria. This was done by the Smiles for Mothers program, a consortium made up of Solina Center for International Development and Research, Clinton Health Access Initiative, and Co-Creation Hub, and is supported by funding from MSD through MSD for Mothers. And Nigeria contributes 19% to the global maternal death toll and is among the countries with the highest burden of maternal deaths worldwide. Sadly, postpartum hemorrhage accounts for 22% of the maternal deaths in Nigeria. And to bring this into a more personal context, I'll be sharing with us the story of Alheri. Now, Alheri is a farmer in Kano State who narrowly escapes death due to postpartum hemorrhage complications. A few minutes after her delivery, she begins to bleed with intense abdominal pain. She bleeds for over 18 hours before being referred to a secondary health facility where she is transfused and eventually recuperates. Now, Alheri is traumatized from this experience and is not looking forward to having another child. Sadly, she is like most Nigerian women who have suffered complications from postpartum hemorrhage. Now, to build on the efforts of the Nigerian government to reduce maternal deaths due to postpartum hemorrhage, the Smiles for Mothers program leveraged the human-centered design approach to support the Federal Ministry of Health and the government of Kano, Lagos, and Niger states to first implement a costed roadmap for the adoption and rollout of medicines aligned with the WHO recommendation on uterotonics, and then to apply this principle to develop innovations to improve access to optimal uterotonics for PPH management. In the process of achieving this goal, the program initiated a responsive feedback mechanism that helped identify other bottlenecks in the process, which I'll be touching on as we move along. We leveraged the 5-step responsive feedback mechanism, integrating it into our 3-phase human-centered design approach to understand the challenges faced by women in receiving appropriate care for the prevention and treatment of PPH. To implement our program, we conducted different activities across the RFM steps. Firstly, to convince stakeholders and uncover our assumption, we carried out what we call a landscape analysis, which enabled us to identify and understand the ecosystem and work collaboratively with stakeholders to gather data and insights, a phase which we call co-research. Now, to highlight learning opportunities, we use these insights to frame design challenges and how might we questions to become an inspiration for ideation to co-create potential solutions, which in our process is the co-design phase. Lastly, we went further to test our solution with potential end users and refined our prototype to guide its evolution, which is the co-refinement phase. I'll be touching more on this on the next slides. To identify the knowledge gap and assumptions, we reviewed existing literature on the current practices on the use of uterotonics and the challenges of service delivery in the States. Went ahead and identified over 20 key stakeholders across the different government agencies, such as the Federal Ministry of Health. These stakeholders were instrumental in implementing the different RFM processes in line with the HCD method. We engaged them further through forum and field activities like capacity building workshops and data collection exercises, where we created personas and journey maps to identify the motivations and pain points of the affected women. This enabled us to gain a better understanding of some of the challenges. We then adapted the participatory approach to testing our assumption using site visits, observations, one-on-one interview methods, where we engaged pregnant women, healthcare workers, including the TBAs. We sampled over 12 facilities and captured insight from over 63 respondents, including key government officials with the State Primary Healthcare Board and the Hospital Management Commission, amongst others. Upon analysis and synthesis of the data gathered from research, a unique experience of a woman known as Miss Hadiza was captured in a journey map. This journey map shows us the key 3 phases from pregnancy, labor, and post-delivery that she experienced. Now, the pain points of Miss Hadiza were: 1, her struggle to remember the dates of her ANC visits and her wish to be reminded of her appointments by her husband, and her prolonged bleeding and labor experience, which she had never had before. This journey map showed us that any intervention or solution to address PPH must take into consideration these 3 key phases from the patient's experience. Other evidence gathered from the field revealed 4 additional insights. One, the unavailability of required temperature-controlled storage and transportation, stock out of uterotonics in the facilities, inadequately skilled healthcare providers, and low awareness of ANC services amongst women. For this presentation, we would focus on the low awareness of ANC services amongst women. This insight was used to frame a challenge statement and create hermeneutic questions that revealed opportunities for brainstorming and ideation, which resulted in the co-design of the Kanu Demand Creation Initiative, or KANAP, for increasing the demand for ANC services amongst women through SMS reminders to them and their spouses. To seek evidence on KANAP, we conducted a prototype evaluation to test and gather feedback on the desirability, feasibility, and cost-effectiveness of the solution. This process revealed key themes in technical design, collaboration, and quality control, which guided the iteration of the solution. Now, some of this key feedback included the technical design, where we're asked to use mobile phone applications to complement the web-based application to enable easy accessibility, especially in rural areas with low technical capacity. For collaboration, mother-in-laws were considered as valuable in the care-seeking behavior of women in the state, and therefore would be a good addition to the solution where possible. Lastly, for quality control, supportive supervision was suggested to be added to the solution to ensure accountability and quality. And these are some of the examples of the feedback that has been integrated and used to further refine the KANAP. One of the challenges we experienced was constraints in time due to the conflicting priorities of our stakeholders. But human and financial resources also guided the method deployed for RFM in Kanu and remain a key consideration as the state institutionalized the process. The impact of RFM on our program has been significant. We have used and will continue to use RFM to ensure continuous impact and drive targeted interventions to address PPH in the state. Before now, our program focused on introducing WHO recommendation for the use of uterotonics in postpartum hemorrhage prevention, with a baseline estimated reach limited to about 21% of women in the state who have already accessed delivery services in health facilities. But now, after applying RFM, we have other insights and we expanded our focus to include community enhancement for demand for maternal services and improving service quality, which is evidenced in other co-designed prototypes, such as the Quali Care solution that aims to improve the management of PPH complications through prompt referral and monitoring of TBAs and CHUs. Also, expansion to the demand-side innovations like CanApp will impact care-seeking behavior, increasing the Smiles for Mothers reach to an outstanding 78.5% of women currently not delivering in health facilities. For sustainability, the program has trained and equipped over 20 champions in Kano State to use RFM to drive innovations across other public health programs and create a multiplier effect. Now on this slide, it shows us the pictures that were taken during the different activities across the different phases. This was where the Kano State champions visited the facility and where we had a one-on-one interview with a pregnant woman. Thank you.